Good morning. Good morning, Dujendra. Yeah, from India, right? Welcome, welcome. Welcome, Dr. Beth, Dr. Dutton, Vashini. Yulia Pinskaya, welcome. All right, let's get started. Let's just go to 45. Welcome to our every fortnightly lunch with Simon. So it's recording me. Do you have the Q&A questions, Simon?
Yes.
Share your screen and let's get into it. We already got a bunch of questions, so thank you for submitting them. If you'd like to submit some questions, feel free to type them into the Q&A box as well. All right, so let's get started. Over to you, Simon.
Okay, so first question is, if a patient has a Mesiodens, is it safe to expand the maxillary? What possible problems may we run into? So if there's an additional tooth, then obviously a decision has to be made in conjunction with the surgeon to arrange to have that tooth removed. Timing wise, some surgeons will have a specific timeline that they want to work from. Whenever I have these scenarios, I generally will expand and complete my expansion process first. That tends to make the surgeon's access easier because often the teeth are stacked on top of each other and hard for the Mesiodens to be accessed. When we have completed the transverse component of the expansion, a lot of the incisors uncrowd and access is often easier. That said, if the Mesiodens is erupted and it's very easy to access, sometimes it makes more sense to remove them first before you do any treatment, because the Mesiodens sometimes gets in the way of the appliance wires. So each scenario is a little bit different, depends on whether it's already erupted or whether it is impacted or kind of crowded internally. Okay, so next question. Regarding the Stanford studies results with Pierrot bands infants, does this change your belief that the maxillary mandibular growth is purely genetic up until 18 months of age? They are able to grow mandibles using environmental stimuli. Could the physical act of breastfeeding, which requires more work than bottle feeding, be considered an environmental factor as well that could help grow the maxilla and mandible? So there are two separate questions there. So we'll answer the first one, which is, we'll answer that based on the science. Right? The science says that the first 18 months or thereabouts, growth of the maxillary mandible is synchondrotic. So primary growth centers. Primary growth, synchondrotic growth, is controlled by genetics. So genetic expression is what creates little babies and up until toddler-ish timelines. Genetics can be affected by the environment. So you get epigenetic change. But that's how the environment affects the genetic development. So being able to obtain a growth change through environmental planned environmental stimulus, such as with the soap appliance from the standard studies, is consistent with this science. So genetic growth, genetics is environmentally affected. Genetics is very powerful, and it takes an enormous environmental stimulus to change it. But early on in our life, the environment has an enormous proportionate component to the genetics because of such rapid cell change and such elastic components in the growth. So we know, for example, the skull will form purely genetically, right? In your entire life of growth and development, there is no environmental component to the growth of your skull. But babies need tummy time or they have flat heads, right? And if they set with flat heads, they have flat heads forever. So they have plagiocephaly cases where they use helmets in pre-12-month-year-old infants to reshape their heads. So genetics has environmental leeway. See, that's the science that everyone understands, but it's the, I wouldn't say the lie, but the misunderstanding the orthodontic profession has fostered to themselves and to our profession, that genetics cannot be environmentally impacted. And the reality, the results of the Sanford study and the results of medicine in general clearly show environmental impact on genetic growth and development is very real. What doesn't change is that at around that 18-month timeline, we shift from primary growth centers, synchronodontic growth, to secondary growth sites, which is environmental adaptation to function and survival from breathing, eating, and speaking. All right, so from 18 months onwards, genetics takes a back seat to the environment. Prior to 18 months, genetics dominates with the environment taking the back seat, but if the environmental stimulus is big enough, then it will change the genetic expression up to 18 months. After 18 months, the environmental factors are actually dominant, all right? Contrary to what we're taught by the orthodontic specialists and what the orthodontic specialists are taught, that genetics dominates jaw growth after 18 months, which is kind of insanity because it's the exact opposite of reality. Okay. Couldn't the physical act of breastfeeding, which requires more work than bottle feeding, be considered an environmental factor as well that could help grow the maxillary mandible? So again, there is an enormous misconception about the concept, the word, the meaning between posture and function. All right. We must be able to differentiate these two terms in how they are acted on and how they affect us. In the simplest terms that I can use to explain, function is the action of physically moving us through space. Posture is a still position held. All right. It's a still position held at rest. Function is us physically moving ourselves in space during activity. So they're two different things. So eating, feeding, breastfeeding, bottle feeding, these are what we call functional actions. Sleeping is called a postural rest. One involves lots of movement and in space, and one involves very little movement in space. Now, there is a merging of those two. It's a continuum, right? Posture and function are a continuum. And that continuum, that variable that shifts us from what is posture to what is function, is explained by time and magnitude. All right? In the simplistic view, rest posture is low magnitude over a long time. Function is high magnitude over a short time. So sleeping is a low magnitude activity over a long time, right? For babies, for example, that is 18 hours a day, right? They're asleep. Feeding is high magnitude over a short period of time. They will feed for how long? 5 minutes at a time, 10 minutes at a time, and then they will have a break for hours at a time. And then they'll feed for 5 or 10 minutes at a time, 20 minutes at a time, and then take a break, right? Feeding overall in a 24-hour timeline will be less than a few hours. Sleeping over a 24-hour timeline will be 18 hours plus. As far as oral posture and oral function is concerned, the action of feeding is very, very powerful. Lots of movement, lots of muscle, lots of activity for a couple of hours a day. Rest posture, sleeping, is where there's no real movement in the mouth for 20 hours a day. What creates the biggest stimulus to growth and development as far as environmental factor is concerned? Posture. How we rest for that long timeline influences growth and development. What we do in short time frames moves us in space, but does not move us biologically. So the single most important concept to understand in posture, right? Because posture is not function, although there is overlap, it's a continuum. They are on two ends of that continuum. So they cannot be confused, or you will never understand what works and what doesn't. Do you have any specific diet books, food recommendations for kids to chew for their daily exercise? Vegetables, yes, but what else? It's not it's to do with how they rest after they've chewed and swallowed. So does it actually matter what foods it is for posture to be worked on? No. Would I recommend real minimally processed foods over factory created industrial ultra processed food? Yes, I would. Right, so stuff that you can grow in a garden, stuff that farmers raise would be best. Stuff that you make at home that takes time versus stuff that you buy out of a packet that was concocted in a factory. All right, so use that as your guideline. The more ultra processed something is, the less likely that is beneficial, and more likely that's just for convenience. That said, the goal is what? The goal is chewing with the lips sealed, chewing hard and fast, swallowing with the teeth together, lips together, and not making a funny face, with the tongue in a peristaltic squeeze, swallow. Does it matter what type of food? No, it actually doesn't. Next question. Hello, in your experience, what are the pros and cons of Vivos and Bioblock removable expanders? So in my experience, I have no experience with Vivos, so I can't comment on it. With Bioblock removable expanders, I've created my entire clinical practice around. So very positive experience with very favorable outcomes, and I teach everyone who is interested in using Bioblock removable expanders. I like removable expanders that have the Bioblock design because they have a lot of acrylic to contact a lot of surface area of dental alveolar bone in the lower and the entire palate in the upper. I like that clasps are so retentive that they behave like fixed appliances. I like that I have control in resistance and retention form with the use of the wires at the front and at the back. I like that I can custom design them to suit my needs for each individual patient. I like the expansion rate that I can incorporate using the screw systems that are part of that expansion process. Disadvantages are that this is a compliance-based process, and disadvantages that they don't work as a standalone therapy, that they have to be combined with changes in posture. So the Bioblock removable expanders don't particularly provide favorable long-term outcomes unless they're combined with changes in the posture. So that's why I developed the GOPex method to work symbiotically with the Bioblock removable expanders. Other disadvantages, they work much better in young growing children, and they don't work with the same favorable outcomes once you are in a permanent dentition. Next question, is the Vivos expander a good fit for the 10-year-olds? How do you keep a child motivated to consistently use it? I have no experience with Vivos, so I can't comment on that system. As far as how do we keep a child motivated to use anything, we have to have a family dynamic where the parents set rules that the family follows. And the parents have to be willing to abide by the rules that the clinician sets. So the key to compliance is having a household that is prepared to discipline their children, and having a household that is prepared to use common sense and logic to follow the guidance and the agreed conditions that the clinician sets for compliance-based appliances. What documentation would be needed to have insurance cover the Vivos? I have unfortunately no I cannot comment about anything to do with Vivos. So one of the things that I'm just throwing out there, did anyone ever hear me teach or talk about Vivos? If so, there may be misunderstanding because I have no experience with Vivos. I do not teach anything to do with Vivos. And I'm not sure why I'm being asked questions about something that I don't cover at all in any of my lectures or teaching processes. Next question. Are you able to bracket C to C or 2 to 2 using your cat wires on only hang appliance wires? Yes, you can incorporate fixer brackets on any teeth that don't have clasps attached to the appliances. So normally our appliances are anchored to the primary second molars, so the ears, and there are normally we don't have any wires on the buccal face. So you can combine the Wong stage 1, the Mu Bioblocks, the hang expansers with limited fixed braces from the D to the D, or the C to the C, or the 2 to the whatever you like. Normally in my practice, if I'm going to use limited fixed braces, then I will I'll bracket C to C or D to D, depending on what it is that I'm trying to do. If it's just a tidy up, then C to C. If I'm trying to reduce the curve of spade, then it's often D to D. Do you use the size of the tongue as a gauge to how wide to develop the palate? I'm usually looking at the size of the incisors to gauge how much to develop the palate. So the teeth have to be in a reasonable finished form for everyone to be happy. So if I just use the tongue, then we sometimes run into the problem of having an upper that's far wider than the lower, so you don't have a normal bite. And sometimes you end up with so much space that every visit, parents are asking, what are you going to do about the extra space? When are we going to close the space? So my development is to allow the teeth to fit in the anterior section. Whenever I'm developing transverse development, my goal is to make it wide enough that I can get all the front teeth to fit nicely, and for both upper and lower to sock together in a reasonable occlusion. So our goal, like all orthodontic goals, is to level and align. The same principles apply, whether we're using removable appliances in early intervention or fixed appliances in later intervention. Next question. If the case of a child who keeps popping out or breaking the lower parts, I have an 8-year-old who's currently wearing a lower expander, not a Wong pliers. Would you resort to fixed lower expander to get the job done? Personally, no. Personally, if the lower plate is being flicked out with the tongue or taken out, then I would have a discussion with the parents and the child and tell them that that is against the rules of what we agreed on. And if they can't follow my rules, then we will cease treatment and they can be treated elsewhere, or they can wait until later and have treatment with the specialist orthodontist. So we have specific rules on how to take the plates in and out. There are specific rules about what we can't and what we can do. If we don't follow the rules, then we stop the treatment. Next question is, of course, we have to make sure that our appliance is ultra retentive, because if we don't do our part to make it a retentive appliance, then we can't expect them to be able to wear them full time. So assuming that we have an appliance that is ultra retentive, then their job is just to wear it, not flick it in and out or pop it out. If we're not delivering that, and unfortunately very few appliances other than my appliance or John Mew's stage 2 appliance has any form of retention. And it is expected that children will struggle to keep the lower intakes. So a combination of I deliver on my promise and they have to deliver on theirs. All right, next question. I have used an upper and lower something about Vivos. Sorry, I don't have an answer. Vivos, because I have no experience with Vivos, I don't teach Vivos, and I won't answer any further questions about Vivos. Do you recommend passive mouth taping for growing habitual mouth breather? So generally, I will not use any form of mouth taping, with the exception of right at the end of treatment, when we're just trying to get the last little bit of lip seal resolved. So we need to make sure we've got the right dimensions for a nice closed rest posture. We need to make sure that the nose works, that there's no obstructions in the airway, and that we have made the big muscles do their work, and the vacuum seal of the correct swallow hold the mouth closed passively. And if we're still struggling a little bit with lip competency, then occasionally we'll look at lip tape, but not as a general rule. I'd say 98% of patients I don't use lip tape, but there's no downside to using lip tape at the end, but using lip tape to seal the lips without any consideration about what the teeth are doing, what the tongue is doing, what the nose is, whether the nose is working or not, whether the jaws are in the right shape and place, is potentially disillusional. And if there are airway obstructions, possibly even a little bit dangerous. It's a tool, right? It's a tool that must be used in the right context, in the right environment, for the right child, for the right situations. When the permanent teeth are verge of eruption, do we need to wait till the teeth comes into occlusion for giving appliances? So we have to be very mindful of creating appliances that require some form of stability in order to be able to fit nicely. So changeover times are times that I recommend we don't start treatment. So what are changeover times? 6 is a typical changeover time, where 6-year-old molars are erupting, lower incisors and upper incisors are erupting. So that's usually not a good time to treat, because if your appliance is expected to fit, it needs to be able to be fitted in an environment where things aren't falling out and things aren't moving about. Another typical change over time is 11. So normally we'll treat before 6 if it's a very severe case, or we'll treat around 7 after the 6s have socked in. And then early intervention really has little place in the equation after 10. But that's biological age and not necessarily chronological age. Right? So biological age has to be the primary consideration there. But yes, I mean, if things are erupting, best not to be fiddling around trying to make something for them. Once they've, cut through and you have a good idea of where those teeth are, you can make appliances to allow for that eruption path. It's not a hard, fast rule. It's a solid guideline that we follow to ensure that you're not building appliances that aren't ever going to fit properly. So 3D printed fixed palatal expander for the mandible. There is a metal frame that hugs the dental alveolar ridge pretty closely. Would you say this will work similarly, but not better than acrylic appliance? I would only use this in case kids who cannot keep the lower appliance in place. I have no experience with fixed appliances that hug the dental alveolar ridge. So one of the big issues that we have with any appliance is hygiene. So a big problem that we have with all appliances is hygiene. So part of the benefit of removable appliances is you can take them out, you can clean them, and you can brush the mouth, clean the mouth properly. Anything that's fixed in place is very difficult to clean, and large components that are fixed in place can be extremely problematic for hygiene. So that's the only thing I can say about that. In my teaching for postural orthodontics, the only fixed appliance that I recommend are limited fixed braces for anterior tardia. All right, last question. How do you feel about patients doing GOPex? If they have an expander with acrylic coverage, do they need to wait until the teeth can contact? For instance, I have a 9-year-old with right posterior crossbite corrected, but still has full coverage on his still has full occlusal coverage on his removal expander. He wears it 22 hours a day, but does not eat with it in place. Should he do GOPex with expander in or out, trying to correct the mouth breathing? So GOPex is designed specifically with the view of improving posture by refining the normal activities that we do with our mouth. Okay? So the two primary normal activities we do with children's mouths is talking and eating. All right? So we're trying to use GOPex to improve their control of those two basic vital functions, eating and speaking. And our goal is to improve their control by teaching them adult behavior. And the difference between adult behavior and childhood behavior is the level of control. Well, that's basically what it comes down to in the two differences, the refinement of control. Fine motor skills take time to learn. So GOPex, which effectively comes down to really strong table manners and really strong speaking manners, right? And GOPex is defined by chewing with the lips together, chewing hard and fast, swallowing with the lips together, the teeth together, and not using facial muscles in that swallow. So that's GOPex chewing. The second fundamental GOPex is GOPex reading aloud. Our goal is to develop very strong punctuation and speaking manners. So our goal is to speak aloud with the mouth open when we're talking, and then at every punctuation point, we pause when it's appropriate with our lips together, our teeth together, and when it's time to breathe, we pause with our lips together, the teeth together, and we use our nose to breathe. So again, that's developing strong communication skills through appropriate punctuation, basically mouth open when we're in function and mouth closed when we are at rest, right? Whereas full stops are the rest points, so to speak. So that's the purpose of GOPex. And anyone and everyone can do GOPex, right? You can do GOPex with the malocclusion. You can do GOPex even if your nose is a little bit blocked. Can't do GOPex if your nose is obstructed. So they're the only people who can't do GOPex. Even if you have a crossing of the bite, if you have a cross bite, right, class 3 or class 1, a transverse cross bite or class 3 anterior cross bite, in my program, I do not recommend you instigate the GOPex program until that crossbite is resolved. In reality, anyone who can eat and anyone who can talk, irrespective of their occlusion, can learn to refine their speech and to refine their table manners. So GOPex is developed as a standalone product for the public in general, right? We developed it as a book. That book didn't say you have to have a perfect occlusion, you have to be free of a crossbite, you have to be free of medical conditions, right? Basically, if you're eating and you're talking, GOPex is designed to improve the skill level and refine that skill level of basic communication and basic mastication. We recommend that to everyone, irrespective of what state their mouth is in. So during treatment, we do GOPex for all patients other than if they have a traumatic crossing of the bite. That's throwing out their joint or traumatizing their teeth. They're the only people that we delay GOPex until afterwards. We've resolved that. So that's what GOPex is. Now, another offshoot to GOPex is GOPex, or good oral finishing exercises. And that's the basically training for the correct swallow for self-retention. That is done only at the end of our completed process when we are in a reasonable occlusion with a good airway clarity and capacity to rest correctly. So we only train, and that I don't publish as a book to the public because not everyone can do GOPex, right? You have to have roughly a class 1 relationship to do the correct swallow, which is the aim of GOPex. So if you have a malocclusion, I'm not going to teach you finishing exercises. But if you have a malocclusion, I can still teach you how to improve your speech and how to improve your table manners. My program, the appliances are worn pretty much full-time, and their children eat with their appliances in place. We do not have the appliances out of the mouth for normal activities. So that's a stipulation, that's a rule, that's a protocol that is not negotiable. Okay, last question. Last question for the day. ENT consultation for all children who are going for appliance therapy is mandatory for anatomical obstructions. Yes. So that's a statement that I fully support. All right, nothing works if the nose doesn't work. Nothing can improve if the airway is obstructed. Airway obstruction is a primary care vital function medical intervention requirement. All right, so primary care in anything to do with vital function precedes any elective treatment orthodontic. So our job isn't to correct anatomical obstructions. Our job is to be a triage nurse for ENT and sleep physician specialists so that we can screen children who commonly, when they suffer from anatomical airway obstructions, have malocclusion. So we're a good fit for being a triage stop for ENTs. So during my standard evaluation of children, I am evaluating for potential airway obstructions, and when we find them, we will consult with the ENTs, sleep physicians, to help these families manage their children's vital function issues. Okay, fantastic. Great questions today.
All right, thanks, Simon. I'll let you get back to lunch and work. So, yeah, if you'd like to join again in 2 weeks, generally every 2 weeks at this time, I'll let Simon go. Let me just share where you can sign up for next week's, or not next week, but in 2 weeks' time. So it's this link. Now, we give us a day or two before we update. The team will I'll just send that in the chat. Yeah, so as you can see here, the register now button refers to tonight's thing, which is over, right? So this is, well, theoretically people could be joining still, but this, as soon as we hang up, so to speak, this will be over. So you give us a day before my team will update this for in 2 weeks' time, right? So that will be Wednesday, 9 p.m. Central. Simon's lunchtime on Thursday. We have this AI chatbot, which you can play with. It's based on a few thousand pages of transcripts of paid events. So you can, it's in beta, so it's not perfect by any means, and it sometimes wanders around the internet for extra bits and pieces that may not be what my brother would say, as he laments. But it's, it's a cool tool, and use it for entertainment, education, not professional advice. But if you want more of my brother's opinions, obviously join these 45-minute Q&A sessions. I know most of you are past students on, so welcome. And if you haven't checked out the recordings, if you bought a virtual ticket to the event 2 weeks ago, 1.5 weeks ago, then the recordings are up, as you can see. So log into your Teachable platform and you should be able to access it. For those of you who haven't attended our 2-day program, the recordings are available. We've got the special going until the end of the month. It's just $697 if you want the recordings. Let me just share that in here. That's a pretty good price. And it, you can get, the additional Q&A support until the end of September. So it's not just a bunch of recordings. You can join these Q&A sessions every 2 weeks and ask you questions. You can email us, submit them in advance, or submit them as many of you have done so via email. So appreciate the submissions, everyone. There is a bundled offer for those of you who are relatively new to early interceptive. Dr. Wilson was a guest speaker last year. In fact, when you purchase the recordings, it actually includes access to the 2-day event from September 2024. We do this once a year. And back in September 2024, we were at the Hilton in New Jersey for 2 days live, and it was recorded professionally. And we had three guest speakers, Professor Narinder Singh, an ENT. Amanda Wilson came in from Hawaii in person, Dr. Kevin Boyd as well from Chicago. So similar core training from, the 2-day event that is covered, but we had different guest speakers. This year we had Kevin back on a 2-hour presentation on oxidative stress. It was actually very interesting. So it's not just some training. It also includes over 500 pages of very detailed protocols and other resources and practice templates. So for those of you who are quite experienced, it is a good course. And 14 hours of CE. There's only about a month left before you can get the CE with the PACE program. So if you purchase the recordings, you can still get the PACE AGD verification up until July 21st. As the CE partner of ours is renewing their license. So that might take a few extra months, unfortunately. So we can't guarantee the PACE verification unless you submit it before they lose their license. It's been the process of being renewed. The recordings are available until the end of September. So keep that in mind, even though, if you want the verification and do the test, there's a bunch of multiple choice quizzes and tests as well included. But you have access to the recordings if you want to rewatch it, etc., until the end of September. So that is that. And for those of you, who are really quite new, there's Dr. Wilson offered a fantastic course that she developed, a phase 1 interceptive orthodontic course that she put together, 13 hours non-CE. So I get a discount here. This is $397. But you can get a bundle if you want to get her 13-hour course and our 2-day intro program. It's just, I think, $897 for both. So for additional $200, you basically can get a bundled offer. All right. So just send us an email if you're interested in that bundle. Just, as I mentioned, bundle 897. Just email us at info@straightteethnaturally.com, and you can check out Amanda's program here. I'll give you the link as well for that. So that specials until the end of the month as well. If you want the bundled offer, or either one individually, one is $397 until the end of June, and other one is $697. Yes, for those who did our 2-day program, we've got this advanced phase 1 program that you can check out here. We've extended that until the CE test deadline, July 21st. So if you attended our 2-day event back in June 6th and 7th, do check out our updated specials until about July 21st. actually includes Amanda's course and as a bonus and some other marketing training as well. Alrighty, that's about it. Any questions logistics wise or anything if you'd like to submit raise your hand or whatever, we'll try our best to answer. Otherwise, we'll see you in a couple of weeks. I don't think there's any other questions. Thank you for your participation. Have a great evening and take care. Ciao.